first of all, I should say that I've been listening to Oommen talk about heart failure for the past 3 years. And every 3 months, he's updating himself so much. I learned from his talks. First, I should appreciate Oommen for his excellent latest disclosure today. But I think the point that you are asking about, whether to give ARNI throughout without reducing it. Now, practically, let me tell you, I have tried this on a couple of patients and failed. They seem to be landing up with a slight deterioration again. So I think the point is there is clearly a benefit of this, and Oommen clearly highlighted the different subsets of benefits. The arrhythmia, sudden cardiac death, the electrolytes, the anemia. It seems to be affecting all aspects of heart failure and in a beneficial way. There's nothing where you can say it's bad. And if you're not going to do it, you're losing each one of these a little bit. Like little drops of water make an ocean. So that's exactly what's happening when you stop the ARNI. I think that's very, very important not to stop these drugs and continue it throughout. We are seeing a lot of heart failure with improved ejection fraction or recovered ejection fraction, as you had called it. And it is very, very important to continue this for all these patients. I think it's a very, very important message to continue.
Fantastic, Dr. Prabhakar. Good points. Dr. KP Suresh Kumar, your comments about the transition MI that Dr. Abraham covered, NSTMI versus STMI differences. I mean, this is Paradise MI trial. This is interesting because if we look at the overall outcomes, that's not something that where it turned out to be so significant. But he also talked about the Indian data sets, how patients are presenting much earlier, worse, multivessel, diffuse disease, severe dysfunction, late presentation. Do you think that we can think and take a cue from this in terms of starting patients of acute MI on ARNI earlier? Because those patients that were included in the trial were acute phase. A lot of our patients, if you look at whether it's a CREATE registry or Kerala registry, the presentation itself is beyond 36 hours, median durations are pretty late. Can we extrapolate that, especially in terms of LV dysfunction post-MI, to put them on ARNI in our subset of patients? And how good that or safe is that in your experience, as well as from your scientific knowledge, to initiate the patient of acute MI in Indian subsets, especially STMIs, with ARNI rather than ACE or ARB?
Thank you, Professor Kamal Sharma. Excellent presentation, Abraham Oommen. Excellent. Now, as we all know, RNA is a very, very valuable molecule in the foundational therapy of heart failure, and it is effective in all phenotypes: heart failure with reduced ejection fraction, preserved ejection fraction, improved ejection fraction, and all kinds of phenotypes. Then different clinical situations. Paradigm heart failure is the first trial, chronic heart failure, OP setup. Then came acute decompensated heart failure, pioneer heart failure, and Paraglide. Both shows effectiveness at reducing the adverse outcome. Then Paragon heart failure with preserved ejection fraction. Then, as Oommen said, PROVE heart failure, that is with ICD eligibility, just reduce ICD eligibility by 30%. So different clinical scenario, it has proved its effectiveness with a very good p-value. The only clinical situation where it has not shown that much effectiveness is Paradise MI trial, where these acute MI situations. Actually, it is the same with MPACT MI trial also, and with empagliflozin. Both acute MI is a totally clinical situation, to a different clinical scenario. Maybe more of reperfusion phenomenon, deperfusion problems, and perfusion problems, and ventricular arrhythmias are more important than cardiac failure at that moment. The initial, it's a different clinic, different ball game altogether. And other things, the event rates may be less because most of these patients are revascularized. So event rates are better post-MI care. That may be the situation why it has not reached the p-value. Still, the outcome is 10% improved compared to the controls. So another thing about this RNA is that most of the trials is compared with an active counterpart. Paradigm with an enalapril, and this Paragon with I think valsartan. So it has not compared with a placebo, compared with an active competitor with this a significant p-value. So it's a very, very important molecule in our clinical practice to reduce the heart failure mortality. Thank you.
Thank you, Dr. Suresh Kumar. Very well explained. Thank you. There are a couple of questions that Dr. Afreen has shared in the chat box. I think we can take our experts' comments on that as well. Dr. Arindam, the question is about exploring the role of ARNI in resistant hypertension, how good it is in terms of safety and efficacy. I do tend to use in a lot of my patients where the blood pressures are good. Good enough to let me allow to be initiating this patient, especially if I find a signal for PEF. HFrEF, of course, there is no doubt. You would go in with this drug, but just pure hypertension, especially resistant hypertension, Dr. Pandey, your comments as to how do you choose this over, say, ACE or ARB?
A very interesting question, actually. As you mentioned, we are using some of the physician cardiology are using it, but it is totally evidence-free zone. There is some evidence, probably some Japanese small trials, which are actually evaluating the role of ARNI in resistant hypertension. Now, you find the mentioning of ARNI in the hypertension guideline as well. You rightly mentioned if the patient is having concomitant heart failure with preserved ejection fraction. Now, good subset of this preserved ejection fraction patient may be also having resistant hypertension. So there the choice is very easy because it is supported by the guideline. But as it is a data-free zone, we are using, and actually we are getting good result because this is a very efficient blood pressure lowering agent as well. And in fact, the dose at which we are using ARNI, probably are not using ARB at that high dose. So that also gives us some sort of freedom to utilize the benefit of ARB in the hypertension management with additional benefit of ARNI, which is there in heart failure. So we can use it, but it is not supported by DCGI or guidelines. So it has to be a case-to-case basis. And we need to discuss that with the patient's relative before starting the pill.
Yes, Dr. Pandey. Yeah, Dr. Prabhakar. Yeah, please.
Yeah, see, basically, there is a whole lot of data, like you said, about the Asian patients on resistant hypertension and use of ARNI in hypertension. Now, actually, the Western data has shown a very small reduction in blood pressure. But ARNI in the Asian patients, especially the Korean and East Asian patients, has actually shown nearly 20 millimeter reduction in the systolic and 15 to 16 millimeter reduction in the diastolic blood pressure, which is quite remarkable. So there is some data to say it, but I think if you have a resistant hypertension, you don't have a choice. Possibly try to change from an ARB or which we commonly use, because ARBs are more powerful than the ACE inhibitors in terms of BP reduction. Yeah, I think it's a fair enough choice to shift to ARNI.
Your point is well taken. I think we know from Altitude and Atmosphere. Atmosphere was a trial for Derek renin inhibitor, aliskiren. It was showing some promising data, but in Altitude was the one that shut it down because there was increased incidence of stroke. And that's why probably this fear emanates from that we don't know if you go higher up in blocking the receptors. Are you actually creating some trouble? But as you mentioned, we all in our experience find a lot of patients responding pretty much well. I think as far as safety is concerned in terms of hypertension therapy, I don't see much of a challenge. I think Dr. Abraham has shown that in the sickest of the sick patients, where you have all the worries like hyperkalemia, hyperuricemia, worsening kidney function, don't exist. Actually, it's more protective. And in light of that, at least safety shouldn't be a big issue. Of course, we need that to be an RCT to be confirming the same. But as you mentioned, that Dr. Prabhakar was talking, the Asian subset of data, especially Korean data, have shown that there is a good evidence to use this as a therapy. There is no harm in an acute therapeutic window in terms of reduction in blood pressure, which is pretty significant. So I think that point is pretty well taken. There's another question, if we can have, which is about the difference in brands. What is the significance to one-on-one molar ratio? I don't see.
Yes, so Dr. Abhishek Singh had to leave because of some emergency.
Dr. Abhishek, I am not able to see on the screen.
Yeah, he had to leave because of some emergency in the cath. So,
okay.
Yeah.
Okay. So, Dr. Abraham, if you can take that, let's hear from the expert himself. So, what do you think about this 1:1 molar controversy?
I don't think, see, the problem is we have to look at the practicality. There are many, I think there are some slides to show if the benefits or, but fundamentally, ARNI is reduce events. And once we find the I would not say the Indian or generic as good as the originator molecule, then I would not have any problems. So these are the slides which is being it's patented technology, the different brands, not very big trials, but we have some data to support that. If we can have the next slide, we can show the technology. And so the Valsartan sacubitril displays very funny thing. It's a very complex molecule, but they have been having this molecule from 1971, and they didn't know what to do about it till 79, 80 period or 89. So there is intrinsic stabilization of the supramolecular complex by monovalent multi-coordinated sodium cations and water molecules. So this is a very complex molecule. And next slide. So it's a unique salt, and the crystallinity is very important. And there is this is what is so called 1:1 molar ratio. I'm not personally sure whether this 1:1 is the reason for its so much benefits. Nobody has. I'm not aware of different molar ratios being compared in randomized controlled trials, but this 1:1 molar ratio gives good solubility profile, enhanced bioavailability of valsartan. That is very important because go back, please. The valsartan which is in Arni is different from the valsartan which we buy separately. Or 103, this is Dr. McMurray's statement, 103 milligrams of valsartan in valsartan sacubitril combination, 1:1 molar ratio, is equivalent to 160 milligrams of valsartan, which is available or commercially available. So it enhances the bioavailability of valsartan, and it has got a higher dissolution rate. So this molar ratio may be part of it, but the this combination, this crystalline structure increases the bioavailability, and that is very crucial. Next slide. So this is what I was saying. Valsartan has got poor dissolution, but when you combine the solubility and dissolution rate, the rate becomes better. Next. So this is court related. Novartis went to the court against the Indian companies, but court was along with the Indian companies. So making the long story short, our valsartan sacubitril is as good as the innovator, at least experimentally. Next slide. That's all. Okay. So this is the unique patented structure. So the complex molecule, and so sodium cations, water molecules, and the molar ratio is sacubitril 1, valsartan 1, sodium cations. So the 3:2.5. So that is the ratio. And with this ratio, the efficacy is as good. We do not know what is better. Next slide. So the claim is that valsartan in Azmarda is more bioavailable than valsartan in any other marketed tablet formulations. But we have to, my personal take on all these things is, if the medicine is not given, whether it is the 1:1 molar or whatever it is, it doesn't work. And as such, we are giving only 5 to 6% of our heart failure patients. And we should concentrate there, and implementation is the key. And it's a free country, we can choose, but this particular molecule may have theoretical advantages. That is my take on it. But unless you have to start giving, because what we have found even in tertiary care institutions, once the creatinine goes more than 1.7, 1.8, hardly anybody gets RNA. That is the problem. So these are the company slides. So I will give it back to the moderator, Dr. Kamal Sharma.
Yeah, Dr. Abraham, very well taken. I think the important point is that RNA is not equal to 47 plus 23, or whichever way you put 20 milligrams of combo of two drugs mixed into and stirred into a tablet. That's not what the molecule is. Molecule is different. It's the racemic mixture, and it needs to be covalently bound between the two of them. So I think that is an important message. As you are rightly mentioning, that probably we don't have a head-on trial to compare the outcomes in terms of pharmacodynamic effects. But yeah, pharmacokinetics, we do know that the serum levels attained by the original molar complex is probably going to be more for valsartan as compared to the other. The question that is there in the chat box is for the resistant hypertension. I think we've already taken that. In atrial fibrillation, Dr. KP Suresh Kumar, if you can take AF as a subset and patient has got heart failure with preserved ejection fraction, do you think this is a good subset to initiate RNE, or because Dr. Abraham was mentioning about different subsets amongst the HFpEF, where how you can determine as to who probably will benefit. We'll take comments from each of you, and then maybe Dr. Abraham can also come in with his comments as to who in the HFpEF subgroup are the ideal candidates who probably will benefit more. Dr. KP Suresh Kumar first.
Yes, Dr. Abraham has shown us what are the different ways how RNA benefits in people with heart failure. However, the one word answer it ultimately produces a reverse remodeling of LV. So it reduces the myocardial stiffness, it produces reverse remodeling of LV, it changes the LV volume, shape, everything favorably. It reduces the MR, it reduces the LI size, definitely it reduces the incidence of atrial fibrillation. So it is found to reduce the incidence of atrial fibrillation by improving its by its effect on LV and LA.
So
If I want to make one point, actually, paradigm heart failure trial, all the aspect it showed benefit except atrial fibrillation. Actually, we expected a lot out of RNA because it had failed very seldom. But somehow, if we go by the evidence, atrial fibrillation is one particular subset of patient. Even SGLT2 inhibitor, now we can see multiple meta-analysis which has shown that it gives benefit in atrial fibrillation, the burden as well as the recurrence in paroxysmal atrial fibrillation. But somehow I don't know why, because mechanistically it should actually work because it will reduce the LV volume, LA volume, but evidence-wise there was no benefit, no statistically significant benefit in this particular subgroup of patients.
Dr. Prabhakar, you were also trying to say something.
So when you have an atrial fibrillation with hypertension, the ARBs are known to stabilize the atrial substrate. So valsartan is an ARB and part of it should be beneficial. There are small studies from, as usual, from the East Asia, where there has actually been a reduction in the atrial fibrillation compared to ARBs. Smaller studies, nothing really large, but there is some small data to say. But personally, I think that if it is going to be a choice of heart failure with preserved ejection fraction, you are anyhow going to use a RNA, because I think it's fair. I think Abraham showed enough evidence on the Paraglide and the Paragon combined.
Dr. Abraham?
Yeah, I agree. The two aspects to it. It may prevent the development of atrial fibrillation by all these things. That is one. It may reduce the AF burden. Now we are talking about pack years or cigarettes, the lipidias. Dr. Prabhakar will be very happy about it. The lipidias. Similarly, we are talking about the AF burden. So there are some, again, small studies which shown that AF burden may reduce. But people with already having AF, like whether it will make a great difference, we do not know. But the answer to that is they may require a longer time duration to get the benefit. Whereas people in sinus rhythm got the benefit in weeks or months. Whereas people with atrial fibrillation, they are already remodeled LA, remodeled LV. They may take more time, if at all, to get the benefit. But theoretically,
Absolutely.
it should give the benefit.
I think Dr. Arindam raised a very important point. It did not reach a statistical significance, but also the point is that the trial was not driven by that, because what we are looking at is the important endpoints of the study, and you need to stop, because beyond that point, the study, it becomes unethical to continue the study when we know that this trial was terminated much early, and that's why to wait for the outcomes in terms of AF, either you need to design a separate trial which can look into the same in a randomized control fashion. As he also mentioned, that regression of MR, LA fibrosis, all other things were improving. LV's dimension, LA size, LA efficiency, LA function. We know from the Paragon itself, the subgroup data. If all those are improving, why shouldn't the AF burden, occurrence of new onset AF not reduce? But I think Dr. Abraham summarized it pretty well. If you already are in AF, I think we are beyond a point of reversing what already exists. But if you are progressing in that direction, probably the new onset may differ. But as Dr. Arindam mentioned, right now the evidence is not reaching that p-values. But again, the trial was not designed to look into it. And we have, as Dr. Prabhakar was saying, some signals from the small subset of studies which do tell us that it should work out in that patient, subgroup of patients as well. I think this is a question beyond ARNI. I mean, do we have a choice of beta blocker? Let me club it in terms of the ARNI itself. Which beta blocker, if you're giving an ARNI, would you choose to be the most preferred agent? I mean, in patients with heart failure, I assume that's what they are asking, in a heart failure with reduced ejection fraction. So we have 3 molecules. Maybe you can have some insight, maybe, or if you're a fan of nebivolol, maybe think of that as a half one or half approved kinds. But otherwise, we have only 3 choices to choose from. So metoprolol succinate or carvedilol or bisoprolol. Let's have inputs from each one of you. So Dr. KP Suresh Kumar?
I don't think there is any. You should use one of these. That is extended release metoprolol succinate, bisoprolol, or carvedilol. I don't think there is any beta blocker goes better with RNA. I don't think so.
Absolutely. And Dr. Prabhakar?
So my clinical take is that when the blood pressure is high, the vasodilatory beta blocker carvedilol I use. Otherwise, my choice is generally bisoprolol, because in terms of heart rate reduction, bisoprolol seems to be the best. And you would like to have a heart rate of about even 60 or 55, as Javad Butler and Michael Baum keep saying. 60 or 55, we are not going to achieve with any other beta blocker. I think that is where the bisoprolol scores. Metoprolol, to get to that dose doesn't matter. But ultimately, bottom line is one thing. Get a heart rate definitely less than 70, probably 60s. That's less than even 60. I think that is my take on clinical practice.
Yeah, I think I do agree with Dr. Prabhakar. So if the blood pressure is high, my choice is carvedilol. Otherwise, bisoprolol is my natural choice. I can remember, I don't think there are too many trials which has compared head to head, but one small European trial which compared carvedilol and bisoprolol, they showed clearly the heart failure benefit is equal. But if there is underlying reactive airway disease or some component of bronchial asthma or COPD, then probably bisoprolol has an edge over carvedilol, because carvedilol is, as we know, it's non-selective beta blocker. It has some alpha blocking, capacity as well. So if there is lung issue, then your only choice is bisoprolol. If the blood pressure is high, I'll choose carvedilol. Otherwise, in a patient where there is no, compelling sort of thing, then my natural choice is generally bisoprolol.
I think I completely agree. One small data set is from COMET. Only one big trial, randomized control trial to compare the two. Metoprolol tartarate, however, was the salt, not the succinate. So maybe you're blaming the wrong cousin for the therapy. But again, the other criticism that came from COMET was about the dosages. I think the dose of tartarate was 85, and I believe carvedilol was reached up to full dose of 25 BD. So sub-dosaging and the separate salt were the 2 differences, but that's where carvedilol actually did better than metoprolol by 16% additional statistically significant p-value reduction in the event rate. But barring that, as you mentioned, bisoprolol looks like a good choice. That's what I use. Easy to titrate, easy to go on the heart rate, but blood pressure when you're chasing, I think carvedilol would make a good sense. Dr. Abraham, you have any preferences between the 3?
Yeah, I echo what is said, but the most important thing is to reach the target dose is the easiest with bisoprolol, 2.55, 10. And we can uptitrate the other drugs also.
Absolutely.
Because when you reach 25 BD of carvedilol, then to uptitrate others becomes very set unless the patient has got resistant hypertension or some other hypertension. So my choice would be purely along with the beauty of the drug, but the way I can uptitrate to target doses.
Right, I completely agree. Easy to. I think there's no point of hanging around 3.125 of carvedilol for the rest of the life, which unfortunately is a lot of the times that we encounter when a patient ends up in our chamber. So I think in the interest of time, I should probably be taking your closing comments from each one of you. Dr. Arindam, let's go in the reverse order this time. Dr. Arindam, your closing comments on ARNI.
So ARNI is a
In heart
fantastic
failure
molecule.
or otherwise,
I actually, start, thinking in this way that every patient of heart failure should have ARNI on the board. Even the heart failure PGI ejection fraction, if we see the sub-analysis, the women, the ejection fraction less than 55, they also had very significant benefit. So if your diagnosis is very sure that this is a PGI ejection fraction heart failure, I do consider ARNI should be on board. And in reduced ejection fraction, there is no denial of the fact that this is the molecule, in spite of having newer molecule, vericiguat, etc., but this is the molecule which has gained the confidence of every physician and cardiologist, because we have seen many patients where ejection fraction has improved like anything. They were candidate for some device, but now the indication is no longer there. So this is the molecule that has to be there, and it's very fortunate that in India the price has less like anything. So there cannot be any reason not prescribing this molecule in all heart failure patients.
Dr. Prabhakar, your comments.
Yeah, I think Arindam made a good summary. Now, only thing I want to differentiate is any heart failure, you can give SGLT2 inhibitors, you can give ARNI across the board at any ejection fraction, and even MRA. The only drug that is not given in heart failure with preserved ejection fraction is going to be the beta blocker, unless there is a specific indication, because higher heart rates are actually better in heart failure with preserved ejection fraction. There are some studies, we can discuss it on a different forum later. But as far as ARNI is concerned, I think all heart failures, irrespective of the ejection fraction, or whether there is improvement or no improvement, must be on ARNI. And give it at the maximum dose, maximum tolerated dose, try to push it to the maximum tolerated dose.
Thank you. Dr. KP Suresh Kumar.
ARNI is a very important molecule in all spectrum of cardiac failure. And each visit when the patient comes, we should try to uptitrate the dose based upon the blood pressure and try to reach the target dose or the maximum tolerated dose. And you should reduce the dose only if the patient has got symptomatic hypotension. And again, if you look at all the medicine which is used in patients with cardiac failure, ARNI should be the last medicine which you should stop. Thank you.
Dr. Abraham.
Yeah, my take is we have to concentrate also on the quality of life. If you take the 4 pillars, the quality of life was maximally improved by ARNI, maybe followed by GLP-1 in HFpEF. The SGLT2 did not improve the quality of life. And quality of life includes sexual dysfunction. That is very important because India has got a very young population who has MI and heart failure. So that is one important thing. And second message is that medicines don't work if the patients do not take it or the doctors do not prescribe it. So you have to prescribe it and make sure that the patients are taking it. That's my take.
Thank you. Thank you for beautiful messages. I think the message was pretty clear. ARNI as already, they said ARBs killed ARNI, ACE inhibitors. So now I don't know if ARNI is killing the ARBs as well as ACE inhibitors both. But I think it's the time for therapy that is known and is supported scientifically and in clinical trials to not only improve quality of life, but also improve survival and duration for which a patient is going to live, as we know, which was covered, that it's median duration. If we talk, it's 2 years that's added beyond the standard care of MRA and beta blockers. And now we had SGLT2, probably we have at 4 years. And a lot of our EP friends, and we also see that the patients who were previously listed on CRT awaited or heart transplants awaited actually come and tell you that I'm doing much better, take me off the list. So thank you very much. And over to team. Afreen is there? Yeah, over to you, Afreen. Thank you very much.
Yes. Yeah, thank you so much, sir. For Dr. Abraham's query, just 2 minutes. We do have a recent study which has been published in the European Journal of Cardiovascular Medicine with the lab analysis done with the brand Azmarda as compared to the other generic brands which have an FDC as compared to the 1:1 molar ratio which is there in Azmarda, and we'll be happy to share the publication with you post this meeting over email. In the interest of time, we've overshot 3 minutes, but Dr. Kamala and the panel, if there is maybe 1 minute time more, can I ask one question from the company side, please? Yeah, we do have an initiative for the HF clinics, supporting the development of HF clinics, which basically, ranges from patient education deliverables, symptom trackers, disease education, HF training to nurses, dietitian and counselor support, and some diagnostic support as well, including point of care devices. In our endeavor to, sort of excel at this by every passing day, is there any suggestion from the group that for things that should be part of NHF clinics support setup, and maybe how can we improvise on this? If maybe 1 minute, you all can just take a minute to answer this question.
I always say whenever somebody comes and says we do this activity is capture and publish. If you're not capturing data, you're not publishing that data, I think the service is only half done. If you publish it, you actually do better service. So I think you are doing tremendous job in getting screening done for NT-proBNP by the camps, helping them with the diagnostic test, also trying to arrange for some health education promotional activities. But unless you know that's outcome, how healthcare or heart failure support clinics are improving quality of life, I think that goes more than half goes down the drain. I think capture and publish. That's my small suggestion.
If I can chip in, Heart Failure Association of India is developed the process of having at least one heart failure clinic, and this is as per the guidelines of Heart Failure Association of India, which is endorsed by Heart Failure Society of America as well as ESC, in at least one per district. That is at least 1,000 heart failure clinics across the country. It is a non-promotional thing, and the data capturing is very, very important. But India, what happens is data is captured much later and no action is taken on that. There is no science without implementation. So what we are doing is, like, if within 24 hours, the data has to be entered, and if the patient is not on GDMT, that it has to be elevated to the cardiologist or the consultant, and action has to be taken, or a reason has to be given. So without implementation, like, nothing works, because what happens is we see that in registries again and again. And with due respect, the registry data for heart failure is more or less similar across the country. The MI data is similar across the country, and it should not be. It should be different. So the data is, for example, the CKD data in one of the major national registries in heart failure is only 7%, whereas it should be at least 30-40%. So the data capturing has to be the simultaneous data capturing and implementation. Without implementation, there is no science.